Clinical Journal Club, December 26th, 2018. In the New England Journal is an image of a person's hands, and as we can observe, he has 4 black fingers, and both hands are involved with purpuric lesions. We learn that the problem concerns an 84-year-old man who presented with fever, malaise, and discoloration of his fingers and toes. It's been going on for 2 weeks. He's a non-smoker. Physical examination indicates that the peripheral pulses are palpable. We aren't told anything else. The differential diagnosis is Vibrio vulnificus, Polyarteritis Nodosa, necrotizing fasciitis, herpetic Whitlow, and arterial embolism. Well, we can eliminate some of these possibilities almost immediately. Herpes virus is characterized by small blisters, and we see none here. This problem involves the fingers, not the fascia, so we can dismiss necrotizing fasciitis and also Vibrio vulnificus. That leaves polyarteritis and arterial embolism. And I would think arterial embolism is a terribly important differential diagnosis, and surely a careful history and physical examination should be performed. The heart should be particularly carefully examined, echocardiography should be done, and blood cultures should be obtained. And perhaps imaging should be done of the vessels in the hands. However, it would be a bit unusual for emboli to cause 4 black fingers in one hand and none in the other, although both hands are involved. So let's pick polyarteritis nodosa, which is the correct diagnosis. This is a medium to small vessel vasculitis. The condition has been known for 130 years, and we learn that the patient was treated with glucocorticoids and azathioprine and apparently made a pretty good recovery. If we look at the differential diagnosis, this is Vibrio vulnificus. This is a bacterial infection of comma-shaped gram-negative organisms that live in salty or brackish water. They enter the body through breaks in the skin and cause a necrotizing fasciitis, and it's lethal. This particular patient that belonged to this hand required amputation. I'm not sure that he survived. In the United States, this is seen primarily in the Gulf states, but it can occur all over the world and also occurs in Germany. This example here is necrotizing fasciitis, where large fascial planes are involved with rapidly progressive bacterial infections. Doesn't fit with the patient that we just reviewed. Herpes virus, herpetic Whitlow, is a US jargon that's applied to herpes infections of the nail bed and fingers. It's characterized by small blisters. We didn't see those here. And arterial emboli, particularly emanating from the heart, always a possibility, and certainly belong in this differential diagnosis. Polyarteritis nodosa, or panarteritis nodosa. This condition was described by Kussmaul and Meyer at the University of Freiburg in the 1880s. And one thing that they observed was that the inflammation of blood vessels involves all layers of the vessel wall, and therefore their term panarteritis. What they also described was the development of small aneurysms where small arteries branch, as occurs commonly in the kidney, all over the body, but the kidney exhibits this, but also the spleen is a good source to look for these kinds of changes. Livido reticularis is relatively common in polyarteritis nodosa. We don't see any black fingers in these particular examples. The first topic in the New England Journal this week is pancreatic carcinoma. This cancer primarily afflicts middle-aged to older individuals. There's a stark increase with increasing age, both in women and men. The 5-year survival in Germany lies at around 10%. An advance was made relatively recently when it was shown that gemcitabine improved survival compared to placebo or doing nothing. And that chemotherapeutic agent is currently what's applied nowadays in patients that are being treated for this condition, particularly if they've been operated upon. There are a variety of genes that play a role here: KRAS, P53, SMADs, and cyclin kinases. These are genes that are also involved in colorectal carcinomas. One chemotherapeutic regimen that's used in colorectal carcinoma is abbreviated FOLFIRINOX. I love oncologists, they come up with these things. FOL stands for folinic acid. Folinic acid is actually administered to avoid the side effects of 5-fluorouracil, which interferes with 1-carbon unit metabolism, folate metabolism. So to get around this step that's inhibited, folinic acid is administered so that the mucositis and various side effects are decreased. IRIN stands for irinotecan. This is a topoisomerase inhibitor that prevents DNA from uncoiling and duplicating. Oxaliplatin is a platinum-based anti-neoplastic agent that inhibits DNA repair. And this combination of 4 agents was compared to gemcitabine, which has similarity to 5-FU, as you can see from these graphic displays. And I would think that a 4-drug regimen can probably beat gemcitabine. This strategy was tried in almost 500 patients with pancreatic cancer. These are mostly older individuals, as demonstrated on this table. The spread of their disease was somewhat variable, ranging from stage 1 to stage 4. Lymphovascular invasion was present in the majority of these patients that had been operated upon, and surgical resection had been performed in most. And what we see here, disease-free survival was doubled in the FOLFIRINOX group compared to gemcitabine. But their overall survival was also almost doubled, so that after 60 months or 5 years, half the patients were still there, which is still fairly dismal, but a dramatic improvement over the state of affairs that had been. And if we look at various subgroups as shown here, we can see that all the patient groups seem to profit from this therapy. Adverse events, sure. Mucositis, it occurred despite folinic acid. Grade 3 to 4 events, diarrhea, abnormal liver enzymes, paresthesia, and fatigue. But then again, since half the patients receiving the FOLFIRINOX regimen were still there at the end of 5 years, a greater number of patients would have been exposed to these potential side effects compared to the gemcitabine group. So that we can conclude that this is an advance for patients with pancreatic carcinoma and will probably become the regimen of choice. What isn't answered from this study is if perhaps a neoadjuvant strategy would be of value giving chemotherapy before the operations are done, etc. And these possibilities will undoubtedly be tested in subsequent trials. The next topic in the New England Journal, also dramatically important, is osteopenia. That implies a decrease in bone mass, which could occur in rickets, but that's not the issue here. Phosphate-losing syndromes, not the issue here, or also in osteoporosis. Now, osteoporosis is defined as a T-score less than minus 2.5, which implies a 2.5 standard deviation away from the bone density that would be present in a 30-year-old person. Vast majority of cases, obviously, women. So when women are tested, they're compared to women at age 30. And if their bone density is 2.5 standard deviations less than expected, the diagnosis of osteoporosis is established. And we know how to treat osteoporosis. But the gray area is, what do you do with patients that have bone density that's less than normal, but not yet to the level where they're labeled as having osteoporosis? We measure bone density with dual X-ray absorptiometry, as shown here, and that can be done at various points in the skeleton, generally involving the hip joint or the vertebral spine. To treat osteoporosis, we apply bisphosphonates, and these materials are deposited in bone and interfere with osteoclastic activity, but they also have other actions. And they've been a major advance in the treatment of osteoporosis. But again, that's not the issue here. We're talking about patients that have osteopenia that do not yet meet the criteria for having osteoporosis. Solendronate is a convenient bisphosphonate which can be administered intravenously every 12 to 18 months. And once it's in, it's in. So what's done here, 1,000 women in each group, placebo compared to solendronate, 6-year double-blind trial looking at women that had T-scores of -1 standard deviation up to -2.5 standard deviations at the hip joint. They were 65 years or older. Various ethnic subgroups are represented here. Body mass index looks pretty normal. Calcium intake, average. Various other characteristics are shown here, and their T-scores are given. Dramatic effects. Look at this. They even shrunk less in the solendronate group compared to placebo. We know that older persons decrease in height as they grow older because of bone mineral loss, and solendronate decreased that effect significantly, but also non-vertebral fragility fractures or symptomatic fractures or first fragility fracture, irrespective of where this might occur, the radius or vertebral spine or hip joint, etc. A substantial effect in patients receiving solendronate. Every 18 months, intravenous infusion. So if we look at this in terms of a table, we can look at the hazard ratio and how much it's reduced for each of these entities. And in my view, these effects are dramatic and will certainly influence patient care. What's also reassuring, although this wasn't a primary hypothesis, less cancers showed up. That's kind of a positive bonus. And strokes and various other things were not adversely affected. Particularly important is that no atypical femoral fractures, these spiral fractures that are seen in some patients receiving bisphosphonates, occurred, and there were no cases of osteonecrosis of the jaw. So the current trial is a dramatic positive result for soledronate and should influence patient care. The next topic is dermoid tumors. These are basically malignant sarcomas, although metastasis is not the problem here. The problem is continuous growth of these tumors even after excision. And they can also be present, since they can be present all over in the body, in places that are very difficult to approach operatively. What can we do with these patients? Well, it is a sarcoma, and perhaps it would respond to a protein kinase inhibitor. And sorafenib is a candidate because sorafenib inhibits a number of protein kinases, tyrosine kinases, epidermal growth factor receptor signaling, c-KIT, PDGF receptors, VEGF receptors, and the structure is shown here. So patients with refractory desmoid tumors were randomized to sorafenib and compared to placebo, and the endpoint was progression-free survival. In other words, does this drug decrease the growth of desmoid tumors, also referred to as aggressive fibromatosis? Again, a dramatic effect. Sorafenib seems to stop them cold, compared to placebo, which progressed in these patients. And if we look at these waterfall diagrams, with placebo, there's sort of a Gaussian distribution. With sorafenib, the vast majority of patients responded, and the duration of their response in this 36 months of observation was also favorable in terms of sorafenib. And if we look at the supplement, we can see some imaging, MRI imaging, done in patients before and after sorafenib. I think it looks pretty impressive. Most common reason for dose reduction or discontinuation of sorafenib were various skin disorders. So this drug offers additional options to patients with desmoid tumors, rare tumors, but when they occur, very tedious to manage. The next topic in the New England Journal is stroke, and this review is from the Global Burden of Disease Study, and basically what you need to carry away from this is that the global risk of stroke after birth in individuals that have a life expectancy perhaps to 80 years is 25%. We're not talking about risk factors for stroke here. We know what those are. The lifetime risk of stroke is 25% in men and women equally. All kinds of stroke, but mostly ischemic stroke, although hemorrhagic stroke is also included in this analysis. Now, the stroke risk differs across the world, and as we know, people in East Asia have a greater risk of stroke than people in Europe or North America. And this map makes that clear. So in yellow are the countries that at birth, individuals have a 25% risk of stroke. The orange or reddish areas are where strokes are more common, and the bluish to dark blue areas are areas in the world where strokes are relatively rare. Now, the reasons for this are not entirely clear, although the risk factors for stroke are also distributed across the world, and probably the best we can do is lower blood pressure and not smoke. Now, the lifetime risk of stroke decreases as you grow older. This seems counterintuitive, but the mathematics here involves how many years are left for survival. And if you've made it to age 80 without having a stroke, then to make 95, you're probably going to have a greater risk of dying of other factors aside from stroke, and that's why these curves decrease with increasing age. So the lifetime risk of stroke, now you know it, and it's highest in China and equal in men and women, and in the United States and Europe it's 25%. The review in the New England Journal concerns how do we manage patients after they've been treated for cancer. And since, and this is positive news, patients with cancer are more likely to survive, physicians taking care of them need to know what to do. So the first we have to do is imagine what kind of cancer was it. And the problems with head and neck, breast, prostate cancer, colorectal cancer, lung cancer, testicular cancer, etc., are different. So we have to know the problems that are associated with each particular type of cancer, how recurrence might occur, how these patients are treated, what the side effects of the treatments could be, etc. And what do patients with cancer have? The same kinds of things that other patients have: chronic pain, infertility, fatigue, but also conditions that are associated with chemotherapy, such as peripheral neuropathy and cardiac problems and things of this nature, bone loss if they've gotten corticosteroids particularly, various things that are listed here. So this is a very important review for general internists that take care of patients after they've had cancer. Osteoporotic fractures. We've just looked at that. Think about bisphosphonates, the treatment of depression, etc. So this is a review that focuses on these problems. The information is tabular and it can be easily digested, and I encourage you to look at this review in some detail. Here's a patient in the New England Journal. The before picture is on my left. Looks like a bullet. This patient was shot in the knee. The surgeons, probably for understandable reasons, decided to leave the bullet in since it wasn't causing any immediate problems in terms of the joint space. But as we see here, the lead in the bullet degenerated and spread around the joint capsule. And the patient showed up with a hemoglobin of 9 grams per deciliter, had elevated blood lead levels, and had a mini mental score of 24. Looks like he'd be a pretty good candidate for chelation therapy. But apparently he didn't know about the Affordable Care Act and he was lost to follow-up. So we don't know what happened to him. Here's another view of this angiogram from last week with Kawasaki's disease, and you can look at these dramatic aneurysms of the proximal coronary arteries in this 18-year-old patient whose left anterior descending coronary artery closed spontaneously. He was successfully treated, revascularized, and seems to be doing okay. Another paper in the New England Journal concerns death in children and adolescents in the United States. And here are the causes of death. And as you can imagine, motor vehicle accidents are number one. The risk has dropped in half between 2000 and 2016, although now it's going up again. That's good news. But automobile accidents, and I guess we can call them accidents, although they're avoidable, so maybe they're not so accidental, are still far too common in young people in the United States. Second position are gunshot wounds. And disturbingly, a large percentage of these are self-administered in suicide actions. Now, these other items that have been fairly constant over time, I guess, could be considered accidents since they're not immediately avoidable. If we compare the United States with other countries, we notice that the firearm deaths and the automobile accident deaths resemble what's termed low to middle income countries. That's not very positive, and I will not repeat what Donald Trump called these countries. But the pattern is the same. So these problems could be ameliorated. The driving age in Europe is 18 instead of 16. That might be a place to start. And sooner or later, something's going to have to be done about these guns. You might imagine that driving on the farm would be less dangerous than driving in New York City. That doesn't seem to be the case, since the deaths from motor vehicle accidents show a definite rural tendency compared to urban areas. Things could be done here to make matters better. The patient in the New England Journal is an 18-year-old man with diplopia and proptosis of the left eye. And this condition went on for several years, and the question is, what is it? Malignant tumor. These are usually fairly aggressive at this age and wouldn't be expected to be relatively dormant over a period of 2 years. Could it be a vascular problem? Could it be IgG4 related disease? Could it be thyroid disease? These various things were tested, and at least systemically, no positive findings were apparent as shown in this table. Interestingly, ANCA was measured and it was negative. Patient was treated with corticosteroids. Look at this young person. This is Cushing's syndrome. And it's not from God, it's from the patient's doctors. And as we can see, he has ophthalmoplegia. Upon looking to the right, we can see that he has a palsy of his medial rectus. Urinalysis was normal, as were other various tests, and he'd also been treated with mycophenolate mofetil and got cholecalciferol. Perhaps he should have gotten something better. Here's an MRI, and we can see this within his orbit. Some sort of an inflammatory condition is involving his medial rectus. It's possible to have Graves' ophthalmopathy with normal thyroid function tests. Although sole involvement of the medial rectus would be unusual, since the inferior rectus is more commonly involved. IgG4 related disease remains in the differential, and these conditions are discussed here. Could this be sarcoidosis? No evidence. To make the diagnosis of IgG4 related disease, a biopsy would be necessary, since IgG4 levels are commonly normal. Even granulomatosis with polyangiitis used to be called Wegener's granulomatosis until we found out he was a Nazi. He was. So we term this condition granulomatosis with polyangiitis. I wasn't really aware that this condition involves the orbit, but it does. And when it does, 80% of these patients don't have peripheral ANCA. But if you biopsy them, you can see the presence of granulomas and inflammatory cells as shown here. And the biopsy of this patient clinched the diagnosis of granulomatosis with polyangiitis. This was not IgG4 disease, as shown here. The discussant was concerned that this patient should have been biopsied much earlier, since we treat this condition with compounds other than merely corticosteroids, and perhaps this Cushing's syndrome could have been avoided. Cyclophosphamide, but instead, it's 2018 rituximab, and this patient received rituximab and his steroids were reduced, and it seems like he's getting better. The next topic in the New England Journal, very briefly, involves Hamertin. And Hamertin is encoded by the TSC1 and TSC2 genes. And hamartin is a tumor suppressor protein, which plays an intimate role in mTOR pathway, which is involved with cell proliferation and growth. And TSCs break this state of affairs. It's the brake pedal on mTOR pathway. And in patients that have a mutation in one of these TSC genes, develop tuberous sclerosis. And they are prone to develop tumors because hamartin is no longer there to suppress growth. In this study that's reviewed in the New England Journal, and the number is variable. We usually imagine there's about 1 million nephrons per kidney, but the range can move between 200,000 to 2.5 million. The more we have, the less likely we're going to end up on dialysis. And what was done in this mouse study is TSC1 was knocked out. If you obliterate it entirely, the mice die. But if they're heterozygous, they make more glomeruli. They make more nephrons. And that was shown in this study because TSC1 hamartin seems to have some influence on the development of nephrons during embryogenesis and development. And that's particularly shown here. The heterozygous knockouts have more nephrons. Oddly enough, and not explained in this study, is that they don't get tuberous sclerosis. And it's not known that patients with tuberous sclerosis have more nephrons. So much for that. Another short in the New England Journal concerns the development of antibodies against complement factor H. And in this little case report, we see a patient with membranous nephropathy that indeed has phospholipase A2 receptor antibodies. Subsequent to treatment, he develops another set of antibodies against complement factor H, which seems to further mediate his disease. That's important because the animal model for membranous nephropathy, called Hayman nephritis, involves complement pathway. And the investigators looked at a 92 patient cohort with membranous nephropathy and discovered antibodies against complement factor H in numerous patients. And the implication is here that since we can address complement factors therapeutically, we might have another option to deal with patients that have membranous nephropathy. In The Lancet, we're confronted with the Mayer-Rokitansky-Kuster-Hauser syndrome. If you're not familiar with that, this syndrome that's been known since Rokitansky from the 19th century involves uterus agenesis. Now, obviously, there are genetic factors that must somehow be involved in this condition, but this is not a Mendelian disease. But patients that have this condition don't have a uterus. They have a vagina and all sexual characteristics are normal, and they make ovaries and they make hormones, but they don't have menstrual periods. And if they're examined in detail, their sex organs stop at this point. Now, this problem can be dealt with operatively so that they can lead a normal life, except that they can't have children because they don't have a uterus. But now we have a therapy for women without a uterus, and that is uterus transplantation. And uterus transplantation, we've seen this issue addressed in The Lancet before, has in the past been done from living women donors. But in this example here, a uterus was harvested from a deceased donor that had had a subarachnoid hemorrhage. This woman had had several successful pregnancies, and her uterus was placed at the disposal of a woman with Mayer-Rokitansky-Kuster-Hauser syndrome. Please memorize that. And here's the uterus. They extirpated it. And then there's the problem of transplanting this uterus, and there's some mild intimal fibrosis in the uterine arteries in this specimen, but didn't bother these surgeons. They went on with the problem. And then they had to make a vaginal anastomosis, and they had to attach these various blood vessels and provide venous drainage, and they did that all successfully, and the uterus pinked up when the blood vessels were opened. And a successful result. So this youngster was born to a woman with the Mayer-Rokitansky-Kuster-Hauser syndrome. Various therapies and immunosuppressant therapies were given, but the pregnancy nevertheless proceeded to a successful end. So the added value of this study is one more individual, citizen of Brazil. The next topic involves fibroblast growth factor 21. This is a hormone produced by liver cells that keeps us from doing that. This hormone illustrates the fact that when patients say, gee whiz, doctor, it's in my glands, I must have a glandular problem, they're probably right. FGF21 has been produced recombinantly, and it's now available as a drug. And it has dramatic effects on its own organ, influencing the liver to make steatosis hepatis, non-alcoholic liver disease, non-alcoholic fatty liver disease, to regress. In animal studies, FGF21 should also decrease appetite. And these patients with non-alcoholic fatty liver disease were randomized to FGF21 analog or placebo, and various things were measured. And their livers got less fatty with a substantial reduction after receiving this material for once a week. Interestingly, and unfortunately, I suppose, they didn't lose any weight. So post-hoc analysis also seemed to show benefits. Enzymes got better, and various other parameters considered that are consistent with this condition also improved. So the FGF21 remains as a potential treatment for non-alcoholic fatty liver disease and its subsequent problems. Chikungunya fever. I remember this condition from Southeast Asia. We couldn't differentiate chikungunya fever from dengue fever, except that it's generally less severe and the rash is less pronounced. It's a mosquito-borne fever, single-strand RNA virus, doesn't cause dengue shock-like syndrome, but it would be nice to have a vaccine against chikungunya, which involves half the planet, and Aedes aegypti mosquitoes. This is a vaccine study, and the end point here is the development of antibodies that show an effect in the plaque reduction neutralization test. In other words, neutralizing antibodies against chikungunya virus. Measles virus was a control in this study. Various regimens were given to these normal volunteers, and the positive endpoint is print 50. And we see that over time, antibodies are developed that neutralize chikungunya virus compared to the baseline display where all groups were the same. So this study gives us some hope that a vaccine is coming that protects patients against chikungunya fever. The review in the Lancet is terribly sad and unfortunate. Perhaps something could have been done about this problem when Jimmy Carter was president and Menachem Begin was premier of Israel. Palestinians weren't too interested back then. The Palestinians are shown here in these two areas in yellow, the Gaza Strip and the West Bank. And in these two areas live 5 million people compared to the 500,000 that lived there in 1948. And in Israel, to my knowledge, the population is about 7 million, and 2 million of those are Arabs who are not particularly interested in moving to either one of these places because they have all the rights that any Israeli citizen does. Now, healthcare in the West Bank is poor, and since Donald Trump and other world leaders of a similar ilk have decreased this donations in terms of providing medical care for these people, their outlook is now more dismal. And that's the topic here in this review that's entitled Health and Dignity of Palestinian Refugees. And the UN Relief and Works Agency for Palestinian Refugees has been working on this problem since the refugees lived in tents compared to these very densely inhabited cities that are also inadequate, in which they currently reside. And again, the population has increased tenfold. The medical problems have changed. Malaria, tuberculosis, measles, mumps, etc. have disappeared. And now type 2 diabetes, obesity, hypertension, cardiovascular disease afflict Palestinian refugees as they do all people on the planet. And we can look at the mean number of consultations that are required for these patients are the same as in any adjacent Arab country as shown here. Don't know exactly how to deal with this problem. Interestingly, the wealthy Arab countries that inhabit the Persian Gulf contribute practically nothing to Palestinian refugees aside from funding Quran schools and other fundamentalist directions. That topic isn't touched in this review because the Lancet, if they're anything else, they're politically correct and don't touch issues that might be uncomfortable. The patient in the Lancet, and we'll close with this patient, is another case of lead poisoning. 59-year-old person who was shot by a friend. And superficially here, we can see that it probably was a 12-gauge shotgun at some range, since it didn't blow a hole in him. Can't see this very well in this X-ray. CT helps a little bit, but there are a number of pellets that are also inside the pericardial sac and other interesting areas. The doctors decided to do nothing. So perhaps subsequently, we'll learn about this in several years, this patient might also get lead poisoning, as did the patient in the New England Journal. That's it for 2018. Thank you very much for your attention, and please join me for subsequent exciting ventures into the clinical medical literature.